we move on to next session, session 2. And it is a BECON session. I would like to tell you about the BECON. BECON is a Bangla Eco Consortium. It is formed by, the West Bengal Echocardiography and also Society of the Bangladesh Society of Echocardiography. So can I move on to Dr. Tania and Dr. Tahmina Rahman to conduct this session.
Welcome back, ladies and gentlemen, from home and abroad. We are moving to our second session. The chairpersons of these sessions are Professor Muhammad Nazrul Islam, Professor J. Vijayaraghavan, Professor Abdullahil Shafi Majumder, Professor Syed Azizul Haque, Professor Chaudhuri Meshkat Ahmed, Professor Muhammad Abdullahil Baqui, Professor Muhammad Rahman Babu, Professor Sabina Hashem, Professor Khaled Mohsin, Professor Abhijit Chatterjee, Dr. Debika Chatterjee from India. Now I would like to call the panelists of these sessions, Professor Muhammad Mujibur Rahman, Dr. Amirul Khusru, Dr. Abu Mohammed Shafique, Dr. Dipal Krishna Adhikari, Professor Mohsin Hossain, Dr. Muhammad Mizanur Rahman, Dr. S.M. Quamrul Huque, Dr. M. Kamal Pasa. Our next session, the first speaker of these sessions is Professor Sabina Hashem, Clinical and Interventional Cardiologist from NICVD, Dhaka, Bangladesh, will deliver a lecture on Echocardiographic Assessment of RV function. Now I would like to request Professor Sabina Hashem to present her session.
Assalamu alaikum. Good morning. Today my topic is Echocardiographic Assessment of RV function. So importance of right heart dysfunction in various disease states are pulmonary arterial hypertension, pulmonary thromboembolism, secondary to left heart failure, left-sided valve disease, myocardial infarction with RV involvement, then congenital heart diseases, and ARVD and other systemic diseases. In case of MI, death, CVD, and heart failure, approximately 3 times higher in patients with RV dysfunction in comparison those who don't have RV dysfunction. These are the guidelines from which we'll discuss. So we all know the basic views of echo. So this is parasternal long axis view. And then this is the parasternal outflow view and inflow view. So we all see the LV as well as the RV. Then comes the short axis view at the level of the great vessels, then at the mitral valve level and papillary muscle level. Apical 4-chamber view. So useful for demonstrating RV size, shape, and function. TRZ parameters can be measured in this view. Then comes the focus view. So measure the IV dimension here. And subcostal view. Subcostal view, RV valve thickness best measured, ASDPF best seen. This is useful for evaluation of RV collapse in cardiac tamponade. So right heart assessment, the parameters that can be measured include RA and RV size, RV systolic function, RV diastolic function, pulmonary artery pressures, pulmonary vascular resistance, then 3D RV volumes and RV strain and strain rate. So first come the right atrial measurement. So it is measured in major axis and minor axis. And major axis at the center of the tricuspid annulus to the center of the superior RA wall. It is the parallel to the interatrial septum. And the minor axis, the distance between the lateral RA wall and the interatrial septum at the mid-atrial level. It is perpendicular to the long axis. So measurements are major upper limit is 53 millimeter and minor 44 millimeter. Then comes the right atrial area. So it is measured by tracing the RA blood intertissue interface, excluding the area under the tricuspid valve annulus. So upper reference limit is 18 centimeters square. Then comes the right ventricular function. So right ventricular function can be, these are the basics of RV. It is located behind the sternum, anteriorly positioned to the LV, and muscle mass is 1/6 of LV. Pumps blood against approximately 1/6 of LV. It is accustomed to low pulmonary resistance and hence to low afterload. It is a structurally complex cavity, fits no simple geometric figure, and RV size estimation required integration of multiple views and qualitative and quantitative assessment. So this is the qualitative assessment of RV size. And then comes the measurements. We measure by RV1, that is basal diameter, and it is measured at the maximal transverse diameter at the basal 1/3 of the RV. Then and the upper limit is 41 millimeter. More than 41 millimeter is abnormal. And then comes the RV2, that means D2. So it is measured in mid RV diameter, measured at the level of the papillary muscles, and more than 35 millimeter is abnormal. And the RV length more than 83 millimeter is abnormal. And this is the measurement taken. And another one is our RV to LV basal diameter ratio. So it is taken apical 4-chamber view, and ratio more than 1 measured at the end diastole suggests RV dilatation. So this is the RV, a 4-chamber view, and this is the dilated. That was the normal RV. Here there is dilated RV. Then comes RVOT measurement. It is best viewed from the left parietal long and short axis view, should be measured at the end diastole in curious deflection. So more than diameter more than 33, proximal is considered to be abnormal, and distal more than 27 millimeter indicates dilatation. And then comes the RV wall thickness. It is seen in RV subcostal view, and measurement more than 5 millimeter is abnormal, and it is measured near the tricuspid valve. RV systolic function. So RV systolic function has been evaluated using multiple parameters, like we all know TAPC, then fractional area change, then TDI, derived tricuspid lateral annular S-wave velocity, and then comes RV index of myocardial performance, or RIMP, and 3D-EF, and RV free wall or 2D strain. So TAPC is a mode cursor to be aligned along the free wall as perpendicular to the lateral tricuspid annulus as possible. TAPC is simple, less dependent on optimum image quality, and reproducible. Does not require any sophisticated equipment for prolonged image analysis. TAPC strongly correlate with radionucleotide angiography, and then Simpson, RVEF, and fractional area shortening. It is assumed that the displacement of single segment represent the function of the complex 3D RV structure. Less than 17 millimeter is considered to be abnormal. Then comes the FAC, or fractional area change. So it is obtained by tracing the RV in systole and diastole. It starts from the annulus, then along the free wall to the apex, then back to the annulus along the interatrial septum. So more than 35% is normal. Tissue Doppler imaging, S-wave. So a pulse Doppler sample volume is placed in either the tricuspid annulus or middle of the basal segment of RV free wall. More than 9.5 centimeters per second is considered to be normal. Tissue Doppler imaging measurement taken at the lateral tricuspid annulus in apical 4-chamber view, and basal RV free wall segment and lateral tricuspid annulus are aligned with the Doppler cursor to avoid the velocity underestimation. The disadvantage is that it assumes that the function of a single segment represents the function of the entire ventricle, which is not likely is a condition that includes regionality of the RV infraction. So it will be erroneous in case of regional wall motion abnormalities in the RV. RIMP. So it is an index of global RV performance. So it includes isovolumetric contraction time, isovolumetric relaxation time, ejection time. It can be measured using the tissue Doppler as well as pulse wave Doppler. The tissue Doppler is preferred as it derived from the single sample and requires sample position at the tricuspid valve level annulus like this. See here, you can calculate from a single measurement, and the normal is less than 0.54. And for pulse wave, we have to put a cursor in RVOT and as well as the tricuspid annulus, but it requires the same heart rate. So it might not be possible. So comes the RV diastolic function. So it is from the apical four-chamber view by pulse Doppler to the tricuspid inflow and tissue Doppler of tricuspid annulus. Measurement is similar like of the left side. We all know that. And here grading of RV diastolic dysfunction, EA ratio more than less than 0.8 suggests impaired relaxation. EA ratio 0.8 to 2.1 with E by E prime ratio more than 6 suggests pseudonormal, and E by A more than 2.1 and deceleration time less than 120 milliseconds suggests restrictive filling. It is similar like the left side. And another thing, tricuspid E by E prime more than 6 indicates that raised RA pressure. That is, RA pressure is more than 10 millimeter. And now comes the 3D volumes. 3D dimensional echocardiography is global measure of RV systolic performance, and 3D gives reasonably accurate estimation of RV end diastolic volume and end systolic volume and RV ejection fraction. It is validated against cardiac magnetic resonance. In laboratories appropriate with 3D platforms and experienced 3D derived RV ejection fraction should be considered a method of quantifying RV systolic function. And less than 45% is considered to be abnormal. So this is the 3D imaging. Now comes the global longitudinal RV free wall strain that has been nicely demonstrated by Rakesh Gupta sir. So more than -20 is considered to be abnormal, global longitudinal strains of RV free wall. Now comes the pulmonary artery pressures. So pulmonary artery systolic pressure, it is measured from TR-jet, we all know, and also from pulmonary flow acceleration time. So here, we can see the large TR-jet. Pulmonary systolic pressure by TR-jet, pulmonary artery systolic pressure is equivalent to right ventricular systolic pressure in absence of RVOT obstruction. So pulmonary artery systolic pressure gradient between the RA and RV is equal to A plus RA pressure. And using TR-jet, we use the simplified Bernoulli equation. So 4 into TR velocity square plus RA pressure. Pulmonary artery flow acceleration time is also less than 100 milliseconds, indicate the elevated pulmonary artery systolic pressure. So from shape of the TR-jet, we can also assess the severity of RA pressure, PSP. So that is, this is normal, and if it is triangular like it moderate, raised, and severe, you can get notch in the RB, TR. Here, see the it is like triangular, and here you can see the notch. So it indicates severe pulmonary artery hypertension. Now comes the mean pressure. So it is measured from TR-jet mean pressure and PR-jet mean pressure. So mean pressure mildly elevated 25 to 35, moderately elevated 36 to 45, severely elevated more than 46 millimeter mercury. And PA mean pressure can be located by tracing the TRZ. So if we trace the TRZ, we get the mean and peak pulmonary artery pressure. So here, see the mean and peak. And another one is mean TR gradient plus RA pressure. So if you take the gradient and use add the RA pressure, you get the PSP. And there are some formulas that you can measure the PA pressure. And for the PA, pulmonary artery mean pressure. So it is taken from PRZ. So pulmonary regurgitation velocity represents the diastolic pressure difference between the pulmonary artery and the LV. Pulmonary artery mean pressure correlates with the early diastolic pressure difference between pulmonary artery and RV. So this is the PA, mean pulmonary artery mean pressure. And pulmonary artery diastolic pressure is the second deflection, and it is also measured by Bernoulli equation. That is, pulmonary artery end diastolic pressure is equal to 4 into PR end diastolic pressure velocity square plus RA pressure. It is the newer guideline. They suggest this early diastolic PR velocity more than 2.2 meter per second is considered a marker of raised mean PA pressure. So here is similar thing. Now comes the RA pressure. So RA pressure is measured by IVC method, hepatic vein flow, tricuspid valve Doppler. Raised RA pressure, you can measure from if there is dilated IVC, lack of inspiratory collapse, number one. Number two, E by E prime more than 6, atrial septal left foot bulge, and predominant diastolic flow pattern in SVC or HV. So here, see the dilated IVCs. You can see this one here. That's a smaller IVC. And the new guidelines suggest that the RA pressure measured if the IVC diameter is 21 millimeter or 2.1 centimeter less than that, and the collapsibility is more than 50. So it is the normal RA pressure. So that is 0 to 5. Average is 3. And for intermediate ones, if the diameter is less than 21 and the collapsibility is less than 50, or the diameter is more than 2.1 and collapsibility is more than 50. So these are the intermediate varieties, and the amount is 5. You have to add 5 to 10, or average 8. And high if the diameter, IVC diameter is more than 2.1 and collapsibility is less than 50. So it is high, and you add RA pressure 15 millimeter. So comes the Doppler of hepatic vein. Doppler, you can see if you align the beam to the flow of the hepatic vein in a subcostal view. So you see the S wave velocity here, then D wave, D, that is the diastolic, and SR and DR. So that is the systolic and diastolic reversal. If normally VS is more than VD is normal RA pressure. If the systolic flow is smaller, so elevated RA pressure. Another thing, hepatic vein filling fraction. So less than 55, we have the higher RA pressure, more than 8. I won't go through that. Pulmonary vascular resistance and elevation of systolic pulmonary artery pressure does not always imply the increase of PVR. PVR distinguishes elevated pulmonary pressure due to high flow from due to pulmonary vascular disease. So it is calculated from TRZ, and PVR can be calculated in echo. More than 3 significant pulmonary hypertension exists when PVR is more than 3 Woods units. And this is we can summarize the RV function. So here, TAPC less than 17 is abnormal. S wave less than 9.5 is abnormal. Fractional area change less than 35 is abnormal. And RV free wall strain more than -20 should be is considered to be abnormal. 3D EF less than 45 is considered to be abnormal, and RMPI more than 0.54 is considered to be abnormal, and for pulse wave more than 0.43. And E by E prime more than 6, it is also to be abnormal. So these RV function, it's a jumble of parameters. So if we calculate it in a cool way, so we can measure we can take all the parameters. So my take home message, though neglected, RV function assessment is very important for diagnosis and prognosis of many cardiac and pulmonary disease. Pulmonary hypertension and RV dysfunction associated with increased mortality in heart failure, COPD, and ILD. Proper assessment of RV function is an art. We have to give proper attention in this regard. Thank you. Thank you all.
Thank you, Professor Sabina Hashim, Madam, for your excellent presentation. Now I would like to request our favorite teacher, his legend in the spectrum of echocardiography, clinical and intervention cardiology, Bangabandhu Sheikh Mujib Medical University, Professor Chaudhary Mishkat Ahmed, to shed some light on stress echocardiography.
Assalamu alaikum. Very good morning. My respected teachers in the chairs, the chairpersons, and the distinguished delegates from home and abroad. I do not have any disclosure, but my only disclosure is I'm a promoter of stress echocardiography. Me and my mentor in the chair, Professor Shajul Banerjee, we are promoting the stress echocardiography for more than last 2 decades. We live in an age of coronary angiogram. We sleep with angiogram, we dream with angiogram, we eat angiogram. And we are an angiogram-prone society. But here, I'm going to present you some glimpses of stress echocardiography. I will try to show you the versatility of stress echocardiography. By using those stress echocardiography, you can really save some of your patients from undergoing coronary angiogram, and you're going to do some justice to those patients. So there are some advancement in the stress echocardiography, like the contrast, LV contrast. You can see how nicely the LV can be seen with this contrast echocardiography, and how nicely we can see the viable myocardium. This is a double stress echo test. Also, there have been some advancement with strain, as has been shown by Professor Dr. Rakesh, and also mentioned by Professor Sabina Hashim. And with the use of strain, if there is increase in the strain with the stress, we know the patient is doing well as regard ischemia. And also there have been, this is an abnormal strain. Also, there are some advancement with myocardial contrast echo. And if you can see here, if I just can show you, sorry. Just here you can see during the rest period, there was myocardial contrast taken by all the segment of the left ventricle, but during the stress, the inferior wall is lacking. So we know the classical ischemic cascade, which shows that the early stage of ischemia that is manifested by any imaging is perfusion defect. So myocardial contrast echo could have been a good test in stress echo, but still it is not being recommended so far. So there are many advances in the horizon. We still do not know whether they are going to find out the clinical home, but still stress tests are going to be the key to the coronary angiogram and going to play a vital role in managing our patients. So there are only few modalities of stress echo, especially we'll confine our discussion in between the pharmacological and the exercise echo. although we do have the vasodilatory and the pacing. Some part in the Europe, they perform the vasodilatory echocardiography. As we know, the perfusion in the first stage when the ischemia get caught in those tests. But for all practical purpose, the exercise and the pharmacological stress are there in the table. So these are the physiology that will be very worthy if we can keep in our mind. Dobutamine is definitely a very, it causes contraction, and we can see good contraction with stress echo. But we also have to keep in the mind that the pulse and the blood pressure do not increase up to that extent. We know the way we induce ischemia is the double product of the heart and the blood pressure. But the main purpose of doing a stress for inducing ischemia is really lacking with dobutamine stress echo. What we can see is contraction. But in contrast, if we see the exercise echo, which is very natural and which is very physiological, they really do produce good heart rate and good blood pressure, and eventually they produce good ischemia. So this is our case from our hospital. This patient got admitted 1 month back, 64 years old, diabetic patient. He was having myocardial infarction in the past. Also, on echocardiography, he was found to have myocardial infarction along with ischemic cardiomyopathy. So we did a dobutamine stress echo in this patient. Dobutamine stress echo is for those patients who do have reduced ejection fraction. So this was the ideal case for my patient. And you can see very well that if you compare this cavity and this cavity, you can see there is reduction in the size of the cavity during the stress period. And also you can see the viable myocardium that we were looking for. So we were happy with this test. If we send this patient for revascularization, probably there is a possibility that he will get some benefit from revascularization. So stress echo has got many roles to play, not only for looking at the viability, but also for inducible myocardial ischemia for those patients who cannot exercise. But let me tell you, if a patient cannot exercise, then the choice of stress test should be nuclear stress rather than stress echocardiography. But in certain situations, the dobutamine stress echo has got some role. For example, if the patient shows biphasic response in dobutamine stress echo, if we use the myocardial contrast and we can find the microvascular integrity with myocardial contrast echo, if the left ventricular end systolic volume is less than 130, if the end diastolic wall thickness is less than 6 millimeters, all this information give you a very glimpse about the success of revascularization. So the wide range of scope is there from dobutamine stress echo, where we can make some conclusion about the viability of the myocardium and the potential revascularization in those patients. This is a short summary where we can see the response that we can found in dobutamine stress echo, the typical biphasic response with a viable myocardium, the gradual increase in myocardial thickening when there is stunning of the myocardium, and there will be no response at all if the patient do have no viable myocardium. So this is an interesting slide showing a patient when they do have a sizable amount of viable myocardium, at least more than 70% of the viable myocardium is there. Only in that cases, dobutamine stress echo is going to catch the viability. Otherwise, if the viability is less than less than 70%, it can be detected by the MPI, and dobutamine stress echo will not be able to catch that. But the interesting point is that when we look at this paper, and if we categorically look at the strategy for revascularization, we'll find that if the patient do have the viability of more than 70%, then this patient can directly send to for revascularization. So biphasic response that we get in dobutamine stress echo will make us very confident about sending this patient for revascularization, because if there is any hope, there is hope if we do revascularization in those patients. So what are the uses of dobutamine stress echo? We know for years together, we have been using this as preoperative evaluation, since we and my mentor, Professor Banerjee, we work in a multidisciplinary hospital. We get hundreds and thousands of cases for preoperative evaluation, and we have been doing this test, dobutamine stress echo, for years together. And I can tell you, it's an excellent test, and it has got really, as has been described, 100% of negative predictive value. This slide shows another interesting story about dobutamine stress echo. At a time, the patient with postpartum myopathy, they want to know how they're going to do, what is their prognosis. And particularly in those group of patients, if they show very good contractile reserve in dobutamine stress echo, probably they are going to recover. So to tell the prognostic future of a patient with a dilated cardiomyopathy after pregnancy, this test can be useful. There is another important use of dobutamine stress echo, which is rather under-talked, less talked, unsung story, is its use in left bundle branch block. When a patient do have left bundle branch block, we have the jerky motion in the septum, which really pre-occludes the interpretation of the stress echo. But if you really think about the pathophysiology of left bundle branch block, it is a fan-shaped bundle which just do not only involve the septum, but it is supposed to involve the whole of the anterior surface of the left ventricle. So in patient with LBBB, if you do the dobutamine stress echo, and if you find there is a good motion in other territory other than septum, has good contraction, then you know you are dealing with a normal coronary artery, and only there will be some abnormality in the septum. So LBBB is another good area where we can do this dobutamine stress echo. As we know, the stress spect is not good enough for LBBB. Particularly in this slide, I'm showing you what is the difference between dobutamine stress echo and exercise echo. If you look at the picture, at the top, you can see that despite ischemia, in dobutamine stress echo, the LV cavity is smaller. While in stress echo, the LV cavity during stress is not that small. Why? Because we know dobutamine causes much more contraction. This is one of the limitations why we miss the positive test in dobutamine stress echo. Number one, we cannot really evoke that much of ischemia. Number one. Number two, if we evoke the ischemia, the size of the left ventricle becomes smaller, so that we cannot make really that good interpretation. In that respect, this exercise echo is much superior if we really consider about the sensitivity of stress test. So here we go to our second case, 65 years old male. He was a retired principal of a medical college, hypertensive. He was complaining of exertional chest discomfort. At this age, we know he is having some form of coronary artery disease in his heart. But are we going to send them to the coronary angiogram? No, probably no. Because we have got some tests to tell them the medical therapy is going to do equally good if they have gone equally good to like that of revascularization, maybe even better. So what we did, So we did a treadmill exercise echo. I want to show this slide more and more because in this part of the world, we really do not prescribe this test much. But if you do have a treadmill and if you have an echocardiography machine, then why we are not doing this test all over the country? It is really useful, quite useful. As you can see, particularly in this patient, he was having a normal stress echocardiography. You can well appreciate the size of the left ventricle has been reduced during the exercise. And eventually, if you look at the sensitivity and specificity, it's as good, even better than the SPECT. If you look at the its compatibility with bicycle ergometer, then also it is equally good. The specificity is better, and the long-term prognosis is going to be as good as that of a normal person. And if you compare the long-term survival of a patient with negative stress echo and a negative SPECT, they are going to have similar sort of survival. And this slide should be more appealing because we can see if you just look at the middle two column, you can see that the revascularization and the optimum medical therapy offers equal benefit, even if the patient do have some form of motion abnormality. But if the score is less than, the index is less than 1.7. And one more prognostic factor that we can get from this exercise echo is the left ventricular end systolic size. If the size is less, then again, it is going to have a good prognosis. So we have got so many parameters. The negativity, the wall motion score, the LV systolic diameter, and if you look at this chart, also the information that we get from the exercise test treadmill ETT, which has been very gold standard to show a good prognosis over years and years, and we have got robust of evidence in favor that the patient being well with treadmill, they really do well in their life. So with all these prognostic good factors, I have suggested this retired principal to undergo optimum medical therapy, and I think the decision was very clear on my part. So this is a chart showing the difference between the survival in patient having positive and negative stress echo. These are the few points that we can take into account to make a comment about the long-term prognosis of a patient undergoing stress echo. So this is our last case. He was a 58 years old gentleman. He was having a CABG and he was complaining of chest pain. So particularly in this patient, after seeing the patient have had the pericardiotomy, and his echo ought to show some sort of jerky motion in the septum, we decided to go for bicycle ergometer in this patient. I'm grateful to my mentor, Professor Shadul Banerjee. He arranged this bicycle ergometer in our Bangla Sheikh Mujib Medical University. I'm extremely grateful to Dr. Osmani. He's running the show. And also I'm grateful to Dr. Mustasir, Dr. Yari Mahbub, and Dr. Rasul Amin. Those are the people who really have run the dobutamine stress echo in our university. So particularly in this patient, we had some problem in the LAD territory. So if you look at the chart, during bicycle ergometer, heart rate does not increase, but blood pressure increases. But if you consider the product of the blood pressure and the pulse, the bicycle ergometer produces more stress than the treadmill. So bicycle is the best test probably so far the stress echo is concerned. And on the top of that, we can have a numerous data as regard the right ventricular function, data regarding the mitral regurgitation, newly formed mitral regurgitation always indicates severe ischemia. We can have the diastolic dysfunction estimation. We can have estimation assessment about the valvular diseases and so on things. And again, let me remind you about the ischemic cascade, and we can see that the diastolic function occurs earlier than the systolic function. So stress diastolic function going to reveal the ischemia earlier than the valvulation abnormality itself. This is a study, I think it is one of the very important studies which was done with a patient who were having unexplained shortness of breath, unexplained shortness of breath. And we can see that in those patients, a significant causes could be revealed, because some of them had ischemia. Probably that was the main purpose of doing the stress test. But occult pulmonary hypertension and the diastolic dysfunction could be well revealed. And the patient with unexplained chronic shortness of breath are a very good candidate for bicycle ergometer stress echo. As I said, valvular disease, when we get disparity between the symptom and the severity, it is an excellent test. We can do the Doppler studies and other study to reach in a conclusion. So ladies and gentlemen, please learn to live with stress echocardiography. Please try to love stress echocardiography. If you really can use the different modalities of stress echocardiography, you really can give good guidance to your patient. Don't sleep, don't eat, and don't dream with coronary angiogram alone. Thank you very much for the patient hearing.
Which is stress echo for whom? It was a very informative, brilliant speech. To whom we should perform stress echocardiography. Thank you very much, Professor Chaudhuri Meshkat Ahmed sir, for your excellent lecture. Now we are moving to our third lecture of this session, that will be delivered by Dr. Debika Chatterjee, who is the Chief of Non-Invasive Cardiology from Rabindranath Tagore International Institute of Cardiac Science, India. Now I am requesting Dr. Debika Chatterjee to deliver her speech on echocardiographic assessment of aortic regurgitation.
Thank you, and good morning to everybody. Can you hear me?
Yes, ma'am, we can hear.
Can you see my slide?
Yes, ma'am, clear, thank you.
Okay. And my sincere thanks to the organizer of BTECO 2021. And I'm going to speak on echocardiographic evaluation of aortic regurgitation. Now, when we do the echocardiography in a patient of aortic regurgitation, other than identification of the air jet, which we can see as a very bright colored blue jet coming out of the aortic valve, we also try to get the answer of few questions. Can you see my slide?
Yes, ma'am.
Okay. So we try to find out the etiology of the aortic regurgitation. We try to quantify how severe is the disease, and also we try to see the hemodynamic consequences of aortic regurgitation on the heart. Because answer of these questions will guide us for the line of treatment of the patient. Depending on the answer of these questions, we are going to decide whether we will continue with the medical follow-up of the patient, or we are going to send the patient for the aortic valve replacement to the surgeon. So as soon as we get a patient of aortic regurgitation and we start doing the echo, we start thinking why this valve is leaking. Is the aortic regurgitation is due to abnormality in the valve leaflet, or is it due to the abnormality in the root and the ascending aorta? So basically, we try to find out the etiology of the air, because it is the key to the surgical plan. Surgeon has to plan depending upon the etiology of the valve. We need to look at the aortic root and the ascending aorta very, very carefully, because we get a lot of clues regarding aortic regurgitation from this area. And we need to look at the aortic valve also. Normally, There are three cusps: right coronary cusp, left coronary cusp, and non-coronary cusp, with a central line of closure. And when there is abnormality in the valve leaflet, either due to acquired heart disease or due to congenital heart disease, we get the AR. Here is a congenital heart disease, which is the bicuspid aortic valve, is the commonest congenital cardiac anomaly, and we may get aortic regurgitation. As you can see, it's an eccentric jet, and there are two cusps in the aortic valve. And when you get aortic regurgitation in a bicuspid aortic valve, it's extremely essential to look at the aortic root in the ascending aorta, which may be dilated because of the aortopathy in a case of a bicuspid aortic valve. Very rarely we may get a quadricuspid aortic valve. You see, there are 4 cusps in the aortic valve, giving rise to the aortic regurgitation, which is its commonest complication. And we also may get aortic regurgitation in a case of VSD. As you see, this is a subpulmonic VSD, and RCC is prolapsing in an attempt to close the VSD. And that has resulted in malposition of the cusps, resulting in AR. And that AR causes further trauma to the other cusps and increasing the severity of aortic regurgitation. There is the AR in this case. And when we look at the acquired heart disease, as in the case of rheumatic heart disease, there is AR, and aortic regurgitation in rheumatic heart disease occurs along with the involvement of mitral valve usually. Here you can see the mitral stenosis also. We may get aortic regurgitation in infective endocarditis. As you can see, there is a large vegetation in this bicuspid aortic valve, giving rise to the severe aortic regurgitation. And also we may get aortic regurgitation due to abnormalities in the aorta. One such abnormality is annulo-aortic ectasia, where there is a huge dilatation of the aortic root and the ascending aorta, which we may get in connective tissue disorder like Marfan syndrome or Ehlers-Danlos syndrome. Here the dilated root stretches the valve apart and the cusps cannot meet, giving rise to the aortic regurgitation. And also our AR is present in aortic dissection. As you can see the intimal flap, and look at the aorta, it's hugely dilated. So the cause of AR in a case of dissection of aorta may be various. Like in this case, there is dilatation of the root with leaflet tethering. It might be due to the disruption of the commissures from the wall or prolapse of the dissection flap, or there might be pre-existing aortic valve or aortic root disease. Other than these abnormalities, anatomical abnormalities, we get certain indirect signs of aortic regurgitation, like diastolic flutter of the anterior mitral leaflet. Look at this eccentric jet of air. It's hitting the anterior mitral leaflet in diastole, and that has given rise to the diastolic flutter of the AML. We get enlargement of the LV in chronic AR. So we need to look at the size of the LV, and also, initially the ejection fraction is normal, but subsequently there is a decrease in contractility and resulting in the reduction of the ejection fraction. So other than the size, we also need to look at the ejection fraction by modified Simpson's method. However, LV is not dilated in acute aortic regurgitation. Here the LV is unadaptive, unprepared, and patient goes into pulmonary edema very, very quickly. So this is such a case. You see, there was acute AR due to the trauma in the right coronary cusp. This is the transthoracic view, and this is transesophageal view, giving rise to this torrential aortic regurgitation happened in the cath lab during a procedure. Look at the LV. This LV is not dilated, but the patient went into pulmonary edema immediately. Whatever is the cause, whether it's in the aortic valve or in the root or the ascending aorta, assessment of the severity of aortic regurgitation done under the 3 headings of qualitative, semi-quantitative, and quantitative method. Now, each heading has got several parameters. But we must remember that we never stick to one heading or one single parameter. We need to look at all the parameters. At the same time, we must remember that all the parameters in each of these headings may not move in the same direction with the same intensity. All the parameters may not indicate you towards the severe. Some may indicate towards the mild or even moderate. So what we do, we pick up the parameters which are moving in the same direction, maximum parameters moving in the same direction, and we comment on the severity of the aortic regurgitation. So when we go for the qualitative assessment of the severity, we look at the structural parameters as well as at the Doppler parameters. While looking at the structural parameters, we look at the LV size, which is usually dilated in severe, in chronic severe aortic regurgitation. And if you look at the aortic valve leaflets, in the severe air, it is usually abnormal, as in this case, there is a perforation in the non-coronary cusp, and you can see there is a coaptation failure giving rise to the severe. And in mild case, it is either normal or mildly abnormal. But this type of coaptation failure and plain leaflet indicates towards the severe aortic regurgitation. While looking at the qualitative Doppler parameters in the parasternal long axis with the color flow, we must remember that we never look at the length of the jet of aortic regurgitation. We never look how long it is extending into the LV. We look at the AR jet only in the LV outflow tract. So what are the things we are going to look at? We are going to look at the width of the jet. You see, this is the width of the jet in the parasternal long axis in the LVOT. If you look here, it's only a small central jet indicating mild air, whereas here in this case, there is a severe large central jet or large eccentric jet. These indicate towards the severe aortic regurgitation. We also look at the density of the air jet by doing CW Doppler in the apical 5-chamber view. You see, this is the aortic regurgitation. We make the cursor parallel to the air jet, and then we get the CW Doppler. This is the signal CW of the CW Doppler. Above the baseline is the aortic regurgitation. We look at the density of the jet. In mild aortic regurgitation, it is faint, or even it might be incomplete. Whereas look at this severe aortic regurgitation, quite dense signal. So higher the density of the signal, more significant is the regurgitation, because more blood cells are going out of the aortic valve into the LV, so the density is more in severe AR. We also look at the jet deceleration slope in that same CW signal from the apical 4-chamber view. That we look at this slope qualitatively. In a mild air, the slope will be slower. Look at the pressure half time. It's 508 millisecond. Whereas in this particular case of severe air, look at the slope, it's quite steep with the pressure half time of 201 millisecond. And also we look at a very interesting finding in aortic regurgitation. We look qualitatively at the diastolic flow reversal in descending thoracic aorta from the suprasternal view. So this is the suprasternal view. This is descending thoracic aorta, transverse arch. Normally, this flow goes from above downwards, so there should be only blue flow. Look at these. There is a red flow, which indicates the flow reversal. But if it is for brief period in the early diastole, it indicates mild aortic regurgitation. Whereas look at this patient. there is severe pan-diastolic flow reversal in the descending thoracic aorta. Look at the red color, it's occupying the entire diastole. However, looking at the flow reversal may be difficult to appreciate how long of the diastole is occupied by the flow reversal. So for that, again, we have some other qualitative method, like doing an M mode through this descending thoracic aorta. We pass the cursor, get the M mode, so this gives the color M mode. Here is the end of T wave. So this is end of systole. Blue color indicates systole. The red is the diastole. If you look at this is the entire period of diastole. Look here, it's only in the early diastole. So also in the pulse wave Doppler signal, it's only in the early diastole. So it indicates mild AR. Whereas if we look here in this next patient, where there is severe diastolic flow reversal in the descending thoracic aorta, and I do the M mode. Look at the diastole. Entire diastole is filled up with the flow reversal. So it's a hollow diastolic flow reversal indicating severe aortic regurgitation. So also the pulse wave Doppler signal, the entire diastole is occupied by the flow reversal. So after this qualitative assessment of severity of AR, we go to the semi-quantitative parameters. Again, we have 3 parameters under this heading: vena contracta, jet width, LVOT width ratio, and jet cross-sectional area, LVOT cross-sectional area ratio. So let us start with the vena contracta. As we know, the vena contracta is the narrowest neck of the regurgitation jet. So what we do, we go to the parasternal long axis view and put the color flow. And you see, this is the regurgitation. The entire LVOT is occupied by the aortic regurgitation, but this is not vena contracta. Vena contracta is just below the aortic valve, but the flow continues to narrow, you see. So we freeze and then we measure the vena contracta, where still it is narrow. Here is the aortic valve, it's just after the aortic valve in the LVOT. So here the vena contracta is 0.8 centimeter, indicating the severe aortic regurgitation. But look at this next patient. We measure the vena contracta and we find it 0.3 centimeter, which indicates mild. So this is the semi-quantitative measurement of aortic regurgitation. Another such semi-quantitative measurement is the ratio of AR jet width and LVOT width ratio, and we do the percentage of that ratio. So what we do, we go to the parasternal long axis view, and then we freeze the image, and we then measure the jet height just on the 1 centimeter of the VC towards the LV side. So if this is the vena contracta, it should be within 1 centimeter of the vena contracta, and the LVOT height also is taken at the same cross-sectional level. We never go this side or that side. Wherever we measure the jet width, we measure the LVOT width also. And here in this case, the ratio is only 22%, which indicates this regurgitation is mild. On the other hand, look at this jet. It is occupying the entire LV outflow tract, and we find that the ratio is 85%, which indicates the aortic regurgitation is severe. And while looking at the eccentric jet, this semi-quantitative method measurement is not useful. This has a pitfall, because you see, in this particular eccentric jet of aortic regurgitation due to bicuspid valve, if we look properly, the jet is originating somewhere here near the, it's much more anteriorly towards the RCC level, and then it courses down along the aortic valve. Often it gives a false impression of severe, and moreover, we really can't measure the vena contracta and the jet height here, because it's running, perpendicular to the LVOT. So measurement of the vena contracta, jet height and LVOT height laterally is not allowed. We cannot measure like this. We need to measure vertically. So this type of semi-quantitative measurements are not done in eccentric jet of aortic regurgitation. We follow the other parameters for quantification. Another is the cross-sectional ratio of the cross-sectional area of air to the cross-sectional area of LVOT. So what we do, we go to the parasternal short axis view, put the color flow. This is the aortic regurgitation, that small jet. We remain slightly towards the LVOT, and then we freeze, we zoom the view, and then we measure the jet area, and then we measure the LVOT area, take the ratio. If it is more than 60, then it's severe. If it is less than 5, it's mild. So next to that, we will move to the quantitative assessment, again under the headings of regurgitant volume, regurgitant fraction, and effective regurgitant orifice area. These are the 3 parameters. Now, we always do the quantitative assessment of severity of MR, but we have a habit of not doing quantitative assessment for AR, but which we should do regularly. And if we do regularly, then we become expert in it. So, and it's not very tough. We don't usually we do not follow the PISA method. Rather, we will use the stroke volume. So because you see, regurgitant volume is obtained from a stroke volume across aortic valve minus stroke volume across a competent valve, which
Madam,
might
1 minute left.
Okay, just I'll wrap up. So, and regurgitant fraction, once I get the regurgitant volume, regurgitant fraction is obtained by dividing regurgitant volume with stroke volume across aortic valve, and ERO is obtained by dividing regurgitant volume with the VTI. So we need to have 3 things: stroke volume across aortic valve, stroke volume across a competent valve, and a VTI of air jet in 5 chamber. So here is a patient where we have measured the stroke volume across the aortic valve. You see, so in the step 1, we measure the stroke volume across the aortic valve, 139, and then we measure the stroke volume across the mitral valve, measuring the mitral valve diameter across the annulus, and keeping the sample volume in the midpoint of interannular point. We do the pulse wave and take the VTI of mitral valve. We get 106. So 33 ml is the regurgitant volume. Once we get the volume, we can get the regurgitant fraction of 29%, and the effective regurgitant orifice area is obtained from the VTI of air jet, which is 0.18 centimeters square. So if we fit here, our patient falls in this group of, you see, moderate. It's not moderately severe or severe. So this is the way we grade the severity of aortic regurgitation. And very important is to take the measurement of annulus in the mid-systole from the parasternal long axis view, and of the aortic root and the sinutubular junction and the proximal ascending aorta, because these are valuable. So here I come to an end of my talk. Thank you for patient hearing, and wish you a very happy 2022 in advance. Thank you.
Thank you, madam, for your brilliant presentation as usual. Now I would like to request to talk about assessment of dilated and ischemic cardiomyopathy to Dr. Abhijit Chatterjee from India.
I thank the organizers for inviting me once again to talk on this annual fiesta. I can see a lot of old colleagues and friends of Dhaka, but what I really missed this time is the hospitality of the organizers and the wonderful Bangladeshi cuisine. Incidentally, I am working in Chittagong as a senior consultant in the Department of Cardiology. So the topic here is echocardiographic evaluation of dilated cardiomyopathy and ischemic cardiomyopathy. The terminology has changed to some extent. Really, there is a lot of pathophysiological similarity between idiopathic dilated cardiomyopathy and ischemic dilated cardiomyopathy. So I will use this terminology as the discussion goes on. There are similarities in the pathophysiology, but then these are two different diseases and the treatment also is very different. While you use diuretics and ACE inhibitors and ARBs and maybe ARNI and beta blockers for both conditions, but you use statins and dual antiplatelet therapy only for ischemic dilated cardiomyopathy. So if you want to identify a zebra, look for its stripes. It is important to distinguish between idiopathic dilated cardiomyopathy and ischemic dilated cardiomyopathy. At the outset, it is important to say that it is wrong to call it idiopathic dilated cardiomyopathy because in many cases you see a lot of known causes, for example, alcoholism and maybe cancer chemotherapy with trastuzumab, and maybe some of these patients have a strong family history. So really, all of them are not idiopathic. Let us have some 5 pictures of idiopathic dilated cardiomyopathy. This is, ischemic dilated cardiomyopathy. This is a patient who had old myocardial infarction and who's got a septum and anterior wall which are thinned, scarred, and akinetic. The left ventricle and right ventricle are both enlarged, and the systolic function is very poor. There is also a jerky movement of the interventricular septum. Contrast this with idiopathic dilated cardiomyopathy. The ejection fraction again is very poor. By eye estimation, you can say that it is almost 20 to 25%, but there is global hypokinesis. All the walls are equally bad in contraction. Same patient, look at the parasternal long axis view. What is kinesis? Kinesis does not mean movement to the echocardiographer. It means systolic thickening. Look at the walls, there is hardly any systolic thickening. So this is the characteristic of dilated cardiomyopathy. There is poor systolic thickening in almost every segment. Dilated cardiomyopathy. The annulus is dilated. There is very poor coaptation of the leaflets, and there is an eccentric jet mitral regurgitation. For the young doctors who may be happening to listen to my lecture, this is known as the Quanda effect, that is eccentric jet, and this is very severe MR. See, when there is an eccentric MR, then the MR becomes underestimated if you try to measure the jet area. But then it is important to look whether there is pansystolic regurgitation. Any pansystolic regurgitation, you can close your eyes and call it severe MR. Ischemic dilated cardiomyopathy, from the patient whose echo I showed you before. The septum is thinned, scarred, and akinetic. There is no systolic thickening at all in the interventricular septum. The posterior wall has undergone compensatory hypertrophy, and there is a pericardial effusion seen posteriorly. This is because of the failure and anasarca. This is another patient who I saw earlier this month. He has got a history of repeated myocardial infarctions. No intervention could be done because his renal function was poor, and you can see a dyskinetic effect apex, dyskinetic apex, and very poor systolic function. More about this diabetic and hypertensive patient as we go on along this discussion. A 3-chamber view. See the poor contractility, but the apex is akinetic. Other segments are moving well, especially at the base. Same patient, see the dyskinetic effects, and there is a suggestion of an apical thrombus. Same patient, parasternal long axis view, very poor contractility, and look at the posterior wall, posterior inferior wall, there is thinning, scarring, and echinesis. These are characteristics of ischemic dilated cardiomyopathy. Same patient, short axis at the level of the mitral valve. See the posterior wall, posterior inferior wall. Again, same patient. There are problems with eye estimation of wall motion abnormalities. Now, what I am saying now is from the American Society of Echocardiography's Comprehensive Echocardiography, 3rd edition, which was published earlier during this current year. What is normokinesis? More than 30% systolic thickening. What is hypokinesis? 10 to 30% of systolic thickening. What is akinesis? 0 to 10% systolic thickening. Then what is dyskinesis? It means bulging out or thinning of the myocardium during systole. What is aneurysm? The difference between aneurysm and dyskinesis is that aneurysm is dilated in diastole and remains dilated in systole. Dyskinesis is normal looking in diastole and becomes bulged in systole. The eye estimation of resting wall motion abnormalities is inaccurate. There are intra-observer variations. It means that you ask a specialist to comment and you ask him again 3 days later, maybe he will change his opinion. And of course, there are inter-observer variations. So if you want to distinguish between ischemic and idiopathic dilated cardiomyopathy, you take the help of this 2D strain imaging. 2D strain imaging by speckle tracking analysis predicts death or hospitalization. And what is this technology? You know, the computer selects at random some dots or points on the myocardium, and by a mathematical technique known as fast Fourier transformation, it goes on chasing those dots as the heart moves back and forth during systole and diastole. It notes the distance between the two dots in systole and diastole. During contraction, the distance between the two dots should be less because the heart is contracting. And conversely, the distance should be more during diastole. So this is more accurate and reproducible, and this is an objective method of measuring the regional wall motion abnormality. Now, this has been applied also to the right ventricular longitudinal strain, and that was found to be more highly predictive than TAPSE and left right ventricular ejection fraction in patients with heart failure. So this is from our machine in Chattogram. You can see the bad motion of the apex, and see, this is a scale. This red is good and blue is bad. So you can see the bad movement in the region of the apex, and this machine will also give you the ejection fraction. And one important thing is that don't try to measure the ejection fraction by the M mode. This is not done. It is unscientific. Same patient, free chamber. And we take help of the technology, and we can get a 3D heart model which shows the contractility in various segments and also the different segments by different colors. There are times when the clinician is still in doubt, because it is important to know whether the patient has got viable myocardium, whether there are stenosis. And if there is stenosis, the patient deserves revascularization. So for that, we use dobutamine stress echocardiography. In idiopathic dilated cardiomyopathy, there is generalized improvement in contractility. Of course, the contractility does not become normal, but then it becomes more than what there was in the resting state. And in ischemic dilated cardiomyopathy, the regional warm motion abnormalities will become exposed. And this was exactly what my old friend Chaudhry, Dr. Meskat Ahmed, was saying in his previous lecture. However, all cases are not so straightforward. The gold standard, of course, is invasive coronary angiography, but then you can use CT angiography with calcium scoring. A calcium score more than 400 Hounsfield units strongly suggests that the patient has got obstructive coronary artery disease. And also you can do cardiac MRI. MRI is coming to the forefront mainly because of its ability to show myocardial fibrosis by means of late gadolinium enhancement. Now, you have to understand this, that if there is no fibrosis, it is very unlikely that the failure has been because of ischemic heart disease. Now, the echocardiographer's job is not to tell the diagnosis only. He must also be able to predict the prognosis in a patient of ischemic dilated cardiomyopathy or idiopathic dilated cardiomyopathy. What are some of the features of prognosis? Low ejection fraction, that is too obvious. A large end systolic volume and end diastolic volume. LV mass, LA volume. LA volume is the glycated hemoglobin of diastolic dysfunction. The larger the LA volume, the more, the worse is the prognosis. The various grades of diastolic dysfunction. As the disease progresses, the diastolic dysfunction progresses and portends a bad prognosis. Dysynchrony, pulmonary hypertension, right ventricular dysfunction, severe MR, severe TR, and the absence of myocardial ischemia and viability. All of these will indicate poor prognosis. I will demonstrate some of the echocardiographic features associated with each of these predictors. Left ventricular end diastolic diameter. I repeat that it is better not to measure this by the M mode. We take a parasternal long axis view and measure perpendicular to the long axis at the tips of the mitral valve. We also measure left ventricular end diastolic and end systolic volume. Simpson's biplane method is a good method. And again, I showed you 3D real-time echocardiography. See, this is how we do at the tips of the mitral valve. And for young doctors who may happen to watch this, it is important to keep the junction of the aorta and the interventricular septum exactly in the midline and avoid foreshortening so that the results are repeated over various examinations from time to time. Biplane Simpson method. I am showing you only the 4-chamber, but again, the 2-chamber is also there. It accidentally got deleted here. You start measuring at one annulus, end at the other annulus, go over the apex. It is important that you avoid including the trabeculations. The trabeculations are a part of the blood-filled cavity. They are not a part of the wall. And again, the lateral papillary muscle here is a part of the LV cavity and not of the wall. The computer does the mathematical calculations and gives you the ejection fraction. Systolic function is traditionally estimated by the measurement of the ejection fraction and the ratio of the end systolic volume. This is done by a volumetric method by this summation by Simpson's method that I have already shown. 3D measurements I have also shown. Now, it is important to understand that although ejection fraction is a useful marker of left ventricular performance, it is dependent on the preload and afterload. The ejection fraction is a marker of ventricular load interaction rather than an independent marker of left ventricular contractility. Now, although DCM is traditionally considered to cause global wall motion abnormality, regional variations can occur, for example, inferolateral hypokinesis or akinesis, have been observed in muscular dystrophy associated dilated cardiomyopathy and acute myocarditis. When endocardial definition becomes difficult because of challenging echo windows, the use of ultrasound enhancing agents, echocardiographic contrast, can be extremely valuable. It can permit better visualization of the left ventricular and right ventricular endocardium and facilitate more accurate assessment of dimensions and systolic function. What is more important is that contrast can help diagnose left ventricular thrombus. I have shown global longitudinal strain, and I've also discussed about the fast Fourier transformation. It is an enhanced method of assessing left ventricular systolic performance. It is valuable in unraveling subclinical left ventricular dysfunction, which may be missed by traditional echocardiography. Strain quantification is useful in cardio-oncology for monitoring of chemotherapeutic cardiac toxicity and screening family members of dilated cardiomyopathy for subclinical LV systolic dysfunction. Now, one of the important prognostic factors is LA volume. Again, it is better to measure it in two planes by the modified Simpson's method. We start at the annulus, we trace the interior of the left atrium, end at the other annulus, and importantly, join the two annuli by a straight line. Some young doctors will make this mistake. They will trace the undersurface of the mitral valve. Don't do it. And from the midpoint of the line joining to the two annuli, join the distalmost point and press enter the measure. The computer divides the LA volume into 20 equal slices, just as you cut a loaf of bread into slices, and using the two planes, it gives the LA volume. It is important to measure it in full systole with the mitral valve tightly shut, and importantly, don't go into one of the pulmonary veins because that will cause overestimation of the LA volume. When doing evaluation of dilated cardiomyopathy, whether idiopathic or ischemic, remember not to miss secondary mitral regurgitation. It results from apical papillary muscle displacement and annular dilatation. It is an important cause of adverse prognosis in dilated cardiomyopathy and randomized clinical
1
trial.
minute remaining.
How much time, ma'am? 1 minute. Okay, I'll finish it. I'm near the end. The randomized controlled trials have evidence to support intervention in secondary MR using transcatheter edge-to-edge mitral valve repair. Echocardiographic assessment involves evaluation of potential exclusion criteria, namely severe dilatation, RV dysfunction, pulmonary hypertension, and severe TR. It is important to measure the LV diastolic dysfunction as well, and the two important things that are measured in the AAC recommendation are mitral valve pulse wave Doppler, the RV index of myocardial performance, which can be done by pulse wave or tissue Doppler, and the velocity of tricuspid regurgitation. There are algorithms which tell you which grade of diastolic dysfunction it is. The echocardiographer's job is also the guidance of therapy. For example, in alcoholic cardiomyopathy, reverse remodeling, eligibility for the implantation of AICD, the EF has got to be less than 35%, transcatheter mitral valve replacement and tricuspid valve intervention, timing of left ventricular assist device and cardiac transplantation, assessment of CRT. Although this is based on ECG criteria, there is additional evidence that echo evaluation is of incremental value. Thank you.
Thank you, Dr. Abhijit Chatterjee from India for your brilliant lecture.
Thank you.
Now we are moving to our fourth lecture of this session that will be delivered by Vice Chairman and Founder Director of Kerala Institute of Medical Science, Professor Gobindo Vijayaraghavan, on echocardiographic update of constrictive pericarditis and restrictive cardiomyopathy. I am requesting Professor Gobindo Vijayaraghavan to deliver his lecture. Sir, please unmute, sir.
From your side, can you hear me now?
Yes, sir. You're audible.
Yeah. Look at the constrictive pericarditis and restrictive cardiomyopathy. Why should there be a confusion? Both result in diastolic heart failure. Myocardial diastolic heart failure, non-compliant ventricular myocardium results in restrictive cardiomyopathy. Pericardial diastolic heart failure, non-compliant pericardium, constrictive pericarditis. I would request the echocardiographer to focus themselves. Is the myocardium abnormal and the pericardium normal? It is restrictive cardiomyopathy. Is the pericardium abnormal and the myocardium normal? It's pericardial disease and it's constrictive pericarditis. You can see the two varieties. The first one is the constrictive pericarditis. Second is restrictive cardiomyopathy. There are some things common, as you may see here. Both the atria are dilated, right and the left. Both the ventricles are near normal. It is these similarities which has made all this confusion between constrictive pericarditis and restrictive cardiomyopathy. Pericardial diseases has its own diagnostic signs. You have to look for it. If you search for them, you will never miss the pericardial disease. Look at the myocardium and pericardial disease. Look at the longitudinal strain. The globular longitudinal strain is minus 19.2. It is peaking at end systole and synchronized manner, and it is absolutely normal. The myocardium is normal in constrictive pericarditis, except the late stage. When the fibrosis myocardium is normal, and it can be demonstrated by very well by longitudinal strain. Look at the ventricular interdependence. See, when you look carefully, you find that the ventricles change in relation to respiration within a limited space. In inspiration, the right ventricle dilates, left ventricle is small. In expiration, right ventricle is small, left ventricle is dilated. This phasic changes of ventricular dimension in respiration is unique for constrictive pericarditis. Depending on this, there will be changes in mitral tricuspid flow, pulmonary aortic flow, and these variables are normally not present in restrictive cardiomyopathy. These variables are to some extent normal, but always 10% or less. In constrictive pericarditis, they are far more than 10% and could be diagnostic. And these are the first things to understand. Let's look at the chronic pericarditis. Long history of intermittent chills and fever with cachexia, often presents with ascites and dependent edema, elevated JVP, phasic pericardial rub, often tuberculous in origin in our countries. Look at these echoes. Look at these echoes. This is from a 48-year-old businessman. Febrile illness, 4 weeks, paradoxical caseatic material within the pericardium. The caseatic material within the pericardium can be easily identified. And this is what distinguishes the constrictive pericarditis. If you do the M mode, you find the thickened pericardium. And there is exudative material exudate over the visceral and the parietal pericardium. Thick exudates could be identified. And this is very unique. It's a CT scan, you find the the pericardium is thickened for 0.5 millimeters, and can even find a subcarinal lymph node, indicating this is tuberculous node. A subcarinal lymph node more than 2 centimeters is indicating that it's full of just maybe meeting with tuberculosis. And look at the final stage.
I think there is some internet problem from Vijayaraghavan sir's side. So let's have some questions from panelists. If you want to ask any question to the speaker, you can ask. Anyone have any questions? Dr. Sudhir, you have a question, you told me? Nine. Let us discuss from our chairpersons. May I request Professor Chaudhry Meshkat Ahmed sir to discuss about this session's topic.
Thank you very much. I don't have much to say about the session, but the name of the session was BECON session, Bangla Eco Consortium. 4 years back, we started the journey with BECON. It was an excellent and marvelous conference in Calcutta that we can well remember. It was a very sweet memory. At that time, we had Dr. Debika with us and Dr. Amitav, who has presented today's case. So I'm grateful to them, and I'm grateful to the organizer for getting us together. Thank you very much.
Can I have comments from Professor Nazrul Islam sir?
Actually, I like to congratulate the Scientific Organizing Committee for selecting such appropriately chosen topics about the 5 speakers. Starting with Professor Shabina, I think he has made this RV function a very simple way, how to measure and how to practically do it in our clinical practice. Chaudhry Meshkat actually had met the stressful stress test in a very easier way. And as you know from his presentation, that this can be even practiced in everywhere. For this, I like to congratulate the BSM Cardiology Department with Professor Meshkat and his team for arranging such echocardiography procedures. And I like to request them that they should invite the other cardiologists from other institute to come over there and to have some sort of in-hand training so that they can do it independently. And the next, the two Chatterjees from West Bengal, Shuhona also in Ogrim. Thank you. And Debika has maintained the aortic regurgitation evaluation in a correct form. Though the aortic valve is very nearer to the transthoracic echo, sometimes we cannot align the flow properly. So that is a good idea to evaluate how aortic regurgitation can be assessed and can be assessed in different mode of echocardiography. Cardiomyopathies and heart failure patients are sometimes very difficult to identify what is their origin and what is their prognosis. This has been nicely discussed by Dr. Abhijit, of course, now in Chattogram. And I like to give my homage and my gratitude to Professor Vijayaraghavan, who is possibly the seasoned teacher in cardiology in the whole of India. And he has really maintained these restrictive and constrictive pericarditis and restrictive cardiomyopathies. And as you have heard from Professor Meshkat, that we have started BECON in about 4 years back in Calcutta. And this platform has been created to develop the cooperation between in study of echocardiography and related fields in both of the part of in Bangladesh and West Bengal. And possibly we'll be going to introduce or take some research work in community level and in the academic institution level. So with this, I'd like to thank all the 5 speakers of this present session. And after this, I think,
Thank you very much, sir.
thank you.
As we are lagging behind almost 1 hour, we are moving forward to our next session,